Okay, hello. A big thank you to all the viewers today, or the viewers and listeners today. This is our third education webinar from the college this year. This one today is In Harm's Way, Strategies to Support Patients Dealing with Mental Health. So the reason we have this webinar today is because the College Advisory Service is receiving a lot of calls from physiotherapists who are concerned about the safety and the mental health of patients they're seeing in their practice. Physiotherapists really want to do the right thing, but they're saying to me they're unsure of the best way to help and support the patients in distress. So we're very lucky today. We've invited, and they've arrived, is Dr. Preisman, who's a psychiatrist at Mount Sinai Hospital here in Toronto, and also associate professor at the University of Toronto. We also have Dr. Yvonne Bergmans, who's a suicide interventionist here at St. Michael's Hospital in Toronto, and they're going to help us to work through a few scenarios. We thought that would be the most practical way if we work through 3 scenarios that involve patients who are at risk. The panel members will discuss the scenarios and answer some questions and hopefully help the listeners understand the potential risk and some of the appropriate things to say and strategies to use. So before we start, I want to ask Dr. Preisman, would you mind just giving us a little basic synopsis of mental health in today's society? If you could give us a little overview.
Well, that's a tough question to start with, but I will do my best. So first of all, I want to say that it's really exciting to be here, and I'm always very enthusiastic when people want to talk about mental health. I think mental health isn't its own thing. I think what we want to accomplish today is to send the message that mental health is part of overall well-being. And so that can encompass what we typically think of like disorders and difficulties, but also can encompass wellness and overall well-being, and something that needs to be attended to regularly as much as our physical health and our physical well-being. So mental health in today's society, fortunately, is getting more attention. There's more focus based on our wellness and bringing attention to this component of our overall well-being. And so it's certainly something that I've dedicated my professional life to. And so I think it's extremely important. And I'm glad that there's an audience of practitioners who are interested in talking about it today.
Thank you. So maybe I'll start with the first scenario. We have a patient that's shared with the physiotherapist their shoulder injury was from yet another fight with their partner. And they're scared it will keep happening. The physiotherapist is now concerned that the patient is living in an unsafe environment. The patient does not want the physiotherapist to report the partner. They do not want to report the partner or to the authorities. The physiotherapist is feeling they should say, they should do something, but isn't sure what. And so really, maybe I can start with yourself, Dr. Preisman. What would be the kind of questions we could ask, and should they ask direct questions to the patient about the injury?
So I think it's helpful to talk about some strategies that we might use in terms of helping patients feel heard and understood. So this is, to me, comes across as less of a we urgently have to do something, and we actually might, depending on what the home situation is. And so the scenario doesn't talk about whether there's children in the home, whether there's risk on that level. So I get into that, but in terms of letting patients know that we want to be able to support them, we want to hear what they have to say, and sometimes that can be a starting point as sort of simple as, is it something that you feel comfortable talking more about with me? I'm here to listen. Can I listen? Is there more that you want to share? So something that's open-ended and a starting point for conversation that potentially leads to disclosures, but a sort of openness to hear what your patient has to say. What do you think, Yvonne?
Absolutely. It's about validating the fact that this is a really tough situation. It sounds like it's causing you a lot of concern. And I guess I wonder about, how do you know when you feel safer? And do you have ways in which you can keep yourself safe, or someplace you can go when it gets really scary for you? So again, it's allowing the conversation to emanate from the client and working with what they give us.
And sometimes that leads to, how have you coped with this in the past? What strategies do you use? And we work with our patients, if they're open to it, to creating a safety plan. So I think that's something that any practitioner can participate in. And certainly I think that's something that any person can participate in if they're aware of somebody who's experiencing intimate partner violence, violence in the home, talking about strategies for safety. I think something as healthcare professionals that's important for us to recognize are kind of higher risk times. And so we know that typically male people are likely to be the perpetrators and women to be the victims, although that's not always the case, but that's statistically what we understand. And we also know that there are higher risks of violence around times where somebody in that situation is attempting to leave that situation. So knowing that, there's a resource that I've sent to Fiona and your group that kind of goes over some of those things. And it's helpful, I think, to be aware of when people are most at risk, such that we can highlight that and kind of help them work on potentially a plan for how to get out of the situation. And if they're not at that place and they're not ready to talk about that, that's okay too. You don't need to solve the problem with them. I think just acknowledging that they're in a spot of difficulty, that there are times when they feel unsafe, that we can be there to listen and perhaps be there next time when they want to talk more about it, is a starting point to working towards maybe a safety plan, maybe an exit. But at a first disclosure, I think just indicating that you're there to hear it and work with them wherever they're at in that process is a helpful stance.
And one of the things that I would add to that is giving them a resource list of places that they can call, like the Assaulted Women's Helpline. There's a resource list that is available to all of the participants afterwards, with a number of 1-800 numbers, so that even if they don't have an appointment with us, or they won't be seeing us within the next, short period of time, that they do have somebody that they can reach out to and get some support, as well as those supports can also further talk about strategies and support already what we've said, so that they're hearing it from a number of different places, that they matter and that their safety matters.
I think also helpful to talk about what supports folks have already. So if there are people in their lives that are more informal supports that they can turn to in times of need, then that can be useful as well to help people bolster what their or somebody that they trust, they can turn to them or stay with them, resources in their communities. I think that's to know. So sometimes people in the situation don't feel disclose and feel ashamed or embarrassed, and so there aren't people that know what they're going through. But in the case that they're available to them already, it's helpful to just kind of that they can use those resources, that they can reach out to people even when they're not professional supports as well.
And I think it's important, as you mentioned earlier, Mary, is that it's not just relegated to women who are in unsafe situations. We also have to be aware of the fact that there are a number of men who are in unsafe situations as well. And they really, in a lot of ways, feel quite reluctant to talk about those kinds of things because it's not the manly thing to do. So again, validating how challenging it is and the courage it takes to actually talk about something as personal and as challenging as that.
Absolutely. When we do our assessments, we ask the same screening questions for all of our patients, regardless of age or gender or background, because things like a history of abuse or adverse experiences in life are not specific to any particular demographic. And the other thing to highlight about the intimate partner violence issue is that it's different, all influenced by socioeconomic status or geography. this is something that we need to think about with all of our patients. Because the thickness of your wallet is not at all protective for this type of situation.
I'd like to just pick up on Dr. Bergman, your point about the list. We do have quite a comprehensive list available. Dr. Bergman shared some resources. That will be sent to every participant tomorrow. You'll get that in your email. And I think what you're saying, it could be a very useful resource. Print it out, maybe have it available in your waiting room. Patients can see it. They can see you're serious about wanting to provide support if that's something you need.
Yeah, you can hang it up in your waiting room. You can also have a stack of them because somebody might just surreptitiously take one just in case, and they don't want anybody to know.
Absolutely.
Yeah.
Can I just go back to a point, because I do receive a lot of calls from physios who struggle with this question, and that's how you balance a capable adult's right to privacy, to living at risk, and the concern that the physio is having for that patient's safety. Can I get your comments on that situation?
Well, one of the things that I'm highly aware of is I can't make anybody do anything. I'm not that powerful. And so sometimes the only thing I can do is be a listener and hear the struggle. And ultimately, it's going to be their decision. And I will often say to clients, this is totally your decision. I want to know that you are able to keep yourself as safe as possible, and it's up to you what you choose to do. Know that I'm available just to listen. But that comes from a social work perspective, because I know that as physios, you don't have the counseling piece. However, that doesn't mean that you can't engage in a conversation when you're working with somebody. Right? So it's about recognizing I am concerned about your safety, and if you can just let me know what choices, where you've got safe place, and how you can keep yourself as safe as possible in here. All I can do is identify my concern and know that they have safe space, place, or strategies to go to.
I wonder, Dr. Preisman, do you have any advice? We're working collaboratively, we're working in a healthcare environment. Often physios, they're dealing with patients with chronic pain or problems in their lives. And with the 30 to 45 minutes sometimes that they're spending with the patient is disclosing the distress that they're going through. And they often ask, yes, they know they need to make a note in the chart that's helpful to their collaborative team members. Is there anything in that note that would be helpful?
So I do think it's very helpful to know when somebody has disclosed something or an area that in which they're suffering, because the other folks that work with them and care for them can use that as a starting point. So if a physiotherapist isn't trained in counseling or psychotherapy, somebody else who's part of that care team could pick up on that information that's being brought forward and can use it to do that work. So it's helpful to bring it up. I also think it's helpful to talk to us about what we're documenting. I'm really sorry about the audio cutting out. There are technical people here who are working on it. So I wonder if maybe I'll pass this over to Yvonne, who people can hear, and then when my thing gets fixed, I will speak more about it.
I'm not sure if I'm going to be cutting out as well, am I?
Nope.
I'm good? Okay. I think that we let, as Mary was saying, we let the client know that we do document our sessions with folks, and I will often ask if it's okay if I let folks know that I have some concerns around personal safety. Sometimes they'll say, no, don't tell anybody. So I have to couch it in my note in a way of personal issues of personal safety were discussed. It doesn't mean that I'm going to disclose the details. It does, in fact, identify that these are some of the issues that we did talk about. And that usually, if people are reading their notes, hopefully somebody else is going to be able to pick up on it. It also means that I need to read my colleagues' notes to see what they have done and or discussed as well. We make it fairly clear that when there's a circle of care, everybody in the circle of care is aware of the key issues that someone is experiencing, and that there really can be no secrets amongst the care providers.
Thank you. I'm going to go on to the next scenario, if that's okay. And the next scenario is, maybe Dr. Bergman, you could comment. This is a new patient with perhaps a chronic condition, and you've noticed they're withdrawn, they're sad. They're referencing ideas of suicide and indicate they've said to you they might be better off if they were dead. I wonder if you can have recommendations for physiotherapists how they should respond in that moment when the patient talks this way. Should they make comments? Should they ask more details?
Well, the first thing that I would do is validate and acknowledge the fact that they are struggling and that they must be in a lot of pain, both physically and emotionally. And I would also normalize it in the sense that, yeah, I've heard this from other patients as well, to let them know that they're not alone and that this is something that other people do experience, particularly when they are undergoing chronic pain. The thing that I would want to know is, what would dying do for you? What are you hoping to end? Because rarely do I hear people saying they want to end their lives. More often, I hear people saying, I want to end this misery. I want to end this pain. I don't want to have to do this anymore. This is so hard. And my responses are, you're absolutely right. It is hard. From the perspective of a physio, if you're aware of how long the pain will last, how long the treatment will take, what are some of the experiences they'll have, that gives them information about what they can predict or not predict, which gives them that element of a sense of control. And these are the things you can do with this level of distress, whether that be physical or emotional. What we often find, and my research in working with people with repeated suicide attempts, is that often people are alexithymic. That means that they have no ability to identify or describe emotion. Therefore, what we often get is we get analogy, we get stories, or we get behavior that is the communicator to the deep emotional pain that they're experiencing. So again, when you see somebody who talks about, maybe it would be better off if I were dead, you might say to them something like, well, I notice that you're feeling kind of sad and low. What we want to do is give a language, let them know that we are observing, we are watching them. And, do you want to talk about that a little bit more? So there are a number of ways in which you can go in. You start by the validation of the experience of how challenging things are right now, and that and normalize it in the sense that, yeah, I've heard other people say it as well.
Dr. Preisman, would you mind adding to that?
Sure. So I have a new microphone now, and hopefully this will allow folks to hear me better. I promise I said things that made sense before too, but maybe this will sound better. So I want to pick up on the kind of empathic response piece, because I think when we hear other practitioners who are told something like life isn't worth living, or I don't feel like I can go on, it's really hard to know what to say to that in the moment. And so a lot of the work that I do is working with other physicians and other healthcare practitioners in terms of how might you respond to that. And sometimes something as straightforward as, wow, that sounds like a lot, or I can tell that you're really going through a ton right now. I can hear that you're suffering. Having some phrases in your toolbox that you can use to show that you are empathic, that you validate what the individual is going through, and frankly, sometimes to buy yourself some time when you're not sure what you're going to say next or how you're going to handle the situation. Good to have 4 or 5 phrases like that in the toolkit, so that if you hear something come up for your patients, that you can respond in a way that feels authentic to you. So having phrases that are comfortable, that feel genuine to yourself, help you come across as more genuine.
And sometimes that goes back to not being in problem-solving mode. Somebody tells you that their life is so difficult that it's not worth living. That's as human people who do work where we want to help and fix things, we want to come up with solutions and come up with strategies and problem solve. And a lot of times the highest yield responses are the ones where we do none of that and instead indicate that we hear that there's suffering here, that there's a struggle, and that can be so powerful, because I suspect that somebody who's struggled like that, who's talked to other non-professionals in their lives, have had the, but you have so many people who help you, but you have so much going for you. Maybe you could just exercise more. Maybe you could, whatever the suggestions are, and those things can be useful, and sometimes people just need to feel heard. I think the other thing that's helpful to comment on is the chronic pain piece. So as humans, we can tolerate almost anything as long as we know when it's going to end. So you can tolerate a prison sentence because you can count down the days and you can know when it's over. You can tolerate a tough work day because you know you're going to get out of there at 5 or 6 o'clock. So we have a good way as human people of kind of conceptualizing the countdown part. And chronic pain is really destabilizing because there isn't such an end point. And so people really struggle with that. And in terms of what Yvonne brought up, what would dying do for you? For a lot of people, it's the experience of the pain where there's no sense that it's going to end. So I see people with chronic pain all the time. And some of the work that we do is around how can you have this pain as part of your life and also continue to live in a meaningful way? The pain is part of your life and it doesn't need to be your whole life. And that can be hard to see because symptoms like pain and nausea and dizziness are so profoundly difficult to live with that it gives people that kind of negative thinking. I think also helpful to talk about risk. So when we assess people for risk of suicide, there's a few things we hold in mind. One is that we can do our best to get a sense of where your risk is at now. And part of that is determining whether you are thinking about death and dying. We call that passive suicidal ideation, where you have thoughts that you'd rather not wake up, that you don't want to live this way, versus active suicidal ideation. So you're thinking about taking your own life, which we consider to be more risky. Then within that, we ask our patients, have you thought about taking your life? Have you thought about how you might do it? And ask around, is there a plan? And is that plan one that's realistic, where there's access to those means? So if somebody says, I might overdose on all my medication, do you take medication? How much do you have at home? Is that something that you've prepared for? Is that something that you've rehearsed? And you're trying to get a sense of how serious is that patient about following through with this plan. Do you think that you would follow through? And sometimes folks have a plan and they have a way that they might do it, and they see that as kind of a fantasy of escape that they might use, and they wouldn't for reasons like their family or their faith or whatever is stopping them from doing it. Past behavior predicts future behavior. So if somebody's attempted suicide before, they may do so again. And there are certain risk factors, and those tie into the work that you do, because having pain, poorly controlled pain, lots of medical comorbidities are risk factors for suicide, as well as having a mental health concern. Knowing all of that and doing these kinds of assessments every day, suicide is a rare and difficult to predict event. And so even if we ask all the right questions, and even if we do all the screening and we write a perfect medical legally sound note, we cannot predict what's going to happen when that person leaves after their 30, 45 minutes with us or however long we spend. And that sometimes is hard for us because people like to feel in control, and that puts things outside of our control as practitioners. And so just holding that in mind, that even if you do the most thorough assessment as a mental health professional, you will not always capture folks who are at risk, sometimes because they don't tell us, and sometimes because things change. So how suicidal you feel is a fluctuating feeling. When somebody's with you in your office or on the ward working with you, they may feel differently than they would 2 days after your interaction with them. So around knowing an event has happened and we've worked with that patient, how we might cope with that ourselves as practitioners or as people who have known somebody who's made an attempt or completed a suicide, that even if we do all of the kind of right things, that we can't always know.
And I think just to touch on a few of the points, one is that we can't automatically assume that somebody who identifies that they want to die is somebody who's living with a mental health problem. Suicide's a bit of a diagnostic agnostic. It goes across all of the diagnoses, and then there are a number of people also who haven't been diagnosed with a mental illness as well. And that's where I think the chronic pain piece can play a part. What we also want to find out, or we want to pay attention to, as Mary mentioned, is being genuine and non-judgmental. We don't want to say things like, why would you want to do something like that? Or you've got so much to live for. Those kinds of things identify for the client that they're not being heard, that they're not being believed, and they want to be believed, they want to be heard. And somebody just say, that really sucks. It's really, really hard. And when we're looking at chronic pain, some of the, as I'm sure many of you know, some of the mindfulness exercises can be somewhat helpful in terms of decreasing the intensity of the experience in a particular moment through some of the grounding, soothing, and distraction that mindfulness might offer. And there are a number of websites that are available for people to do those kinds of exercises. When you know that you have a client who's talking about the possibility of ending their life with an access to means, you want to find out very quietly whether or not they are over-medicating on their pain medications and whether or not they take them regularly. And I think that you are in a position to say, so are you overusing some of your meds, or are there any meds you're not taking, and kind of got in a jar somewhere? Because what we want to then do is talk to, say, their family physician, or if they have a mental health care provider, about reducing access to means or limiting how often or how many medications that they get prescribed at one time. I know that it's difficult for some people, and yet it's sometimes what we end up doing is saying, okay, you only get a week's worth, depending on the lethality of the medications. So it means also for the physio to be in communication with the rest of the team who's caring for this individual.
So I want to pick up on that, sorry, just because I think it's helpful to comment on the kind of family doctor piece. And we chatted about this as a group briefly before the webinar started, that when, you know, those things around access to means and prescriptions and things may feel outside of scope of practice to address. And those are definitely things where a family physician who's involved can sort of take the lead around prescriptions, how much is being prescribed at a time, reassessing the medications, the type of medications. And so good, clear communication with the other care providers is so important, so that it's not kind of you alone as the physiotherapist who's managing all of this. It's really helpful to share. And anytime we have a complex or challenging case, I think it's always useful to collaborate with the other care providers that are involved, and especially here. And when somebody turns to you and says that they don't know what to do about this concern, how they feel, how their mood is, how their anxiety is, it's true that they may not have a disorder or a diagnosis, and they might. And when somebody says, you know, they've had this cough, it won't go away, they're not sure what to do, we wouldn't hesitate to say, have you talked to your family doctor about it? Have you seen your family doctor? Have you had a workup for that? And I think anything in the realm of mental health is the same. I think we can encourage our patients to at least start with their primary care provider. I think it's okay to ask, like, is that something you've discussed with your family physician? And encourage our patients to do that, because that's what we would do if they said that, you know, they had a different kind of health concern. And so if that felt outside of our scope of practice, we would say, like, when's your next appointment with your family doctor? You might say, like, is it okay if I reach out to your family doctor? Just let them know that you raised that with me here, so that they can best help you and direct you with that. So I would encourage patients to do that too, because we wouldn't hesitate to do that if somebody said they were having a GI issue or or another type of health concern.
I would also document that the person gave you permission to contact their family doc, and document that you did in fact consult with the family doc as well.
And what about the situation? I get this all the time. The patient has made it very clear they do not want the physiotherapist to talk to the family doctor, to talk to anybody. And the physio would typically add, when is it such high risk that I have that duty to warn, I can break that confidentiality and I can reach out. So you've already talked about the passive moving on the spectrum to active ideation of suicide and asking more probing questions. But is there any other red flags or any indicators you would say to the physio, yep, this has reached a threshold, you may have a duty to warn to break this confidentiality of the patient?
So I think it's helpful to start with why the patient doesn't want the information to be shared. I think that can be a useful thing to address. So certainly when somebody is a capable decision maker, they understand what the implications are of sharing or not sharing that information. As an adult person, like, we consider their capacity to decide that, and so we don't always share within a circle of care, even if we think it's kind of in the best interest of the patient. At the same time, there are things that our patients think about or wonder about when we talk about sharing information that their employer would find out, that it would affect their insurance, that there might be some other implications. And so if we can address those to facilitate communication, I think that's a starting point. In terms of the red flags for kind of acute risk, I would see that as something that's imminently happening right now that poses an imminent threat to that person's safety, the safety of another person, or complete inability to care for oneself. And those are the criteria for what's a Form 1 or an application for psychiatric assessment. And that's something that physicians can complete when they're so worried about the safety of a patient that can bring them into or hold them in a hospital to facilitate an assessment. The things need to be at a point of kind of critical safety where there is imminent risk, like this person has indicated that they're leaving your office and they're going to act such that they would end their life, seriously harm themselves, be violent, or even kill another person, or they've come in and just are functioning so poorly that you're really worried about their very basic self-care, so ability to feed themselves or do very basic activities of daily living without some assistance. So things have to be kind of at that level, I would say, before you would involve, let's say, 911 or reach out. I would also suggest, and this is something that I would do if I'm not sure, ask a colleague. So if you work in a practice with other people and you are not sure how you feel about a case and you are concerned, I think it's appropriate to take a break, make a phone call, ask somebody else. I would not want to be sitting alone making that decision. And so that's a hard thing to know kind of when to report. You're probably beyond calling somebody's family doctor at that point. If there's such imminent risk, you're at a kind of 911, police, EMS sort of place. But if you're not sure, and there's a ton of gray areas with all of this, I would not sit alone with that. I would reach out to a colleague right away.
And for those of us who sometimes can't get a hold of a colleague, I have sometimes used the line, I'm really, really concerned about your safety right now. And this is outside of my scope of practice. And I think you need somebody else's eyes and ears to hear how much distress you're in right now. And I think it would be wisest if you go to the clinic to the Emerge. I'm not sure in some communities whether there's a mental health center or a medical center where there might be somebody with some psychiatric or mental health expertise who can further do a risk assessment that would get more in depth and be more involved, that goes beyond our scope of practice when we're not psychiatrists.
I like that point, just to remind physios, our job is not to counsel. We don't have the training, we don't have the scope. Our job is to be the bridge to experienced staff like yourself.
So
Yeah.
somebody's just asked there, that's popped up on my screen, whether it's appropriate to call 911 without the patient's consent if someone is actively threatening suicide. And I think that's a helpful question to address, because that feels very scary. Like the person has told you not to tell anyone, and at the same time they're actively threatening suicide. And so, without kind of knowing what the official teaching is for physiotherapists, I would say erring on the side of safety is always the right thing. So if there's somebody where you feel really unsafe, and a good question for me is, if this person walked out the door now, would I feel comfortable with that? Would I feel okay going home tonight knowing I let that person leave without receiving any other medical attention? And if the answer is a clear no, if there was some repercussions later, I think if you documented that you had a person who was actively threatening suicide in your practice and you called 911, I think it would be very difficult to find fault with that, because you're acting in the interest of the safety in that moment. And so I don't know, Fiona,
Yeah,
what the...
absolutely. I can reiterate there is a caveat in the privacy legislation that would allow you in those high-risk situations to absolutely break confidentiality.
I
This is
also
a,
would advocate for total transparency and say, this really sucks and I don't like doing it, and you're probably going to hate me for a while, and that's okay, because right now your safety is what is of utmost concern, and therefore I'm going to call for help, because this is bigger than you and it's bigger than me, and we need together to find another person to
I
help
also think
us.
it's helpful to make the analogy to a physical symptom, because I tell my patients, if you had crushing chest pain that was radiating down your left arm, we would be calling an ambulance now. And having active suicidal ideation with a plan to end your life is also a medical emergency.
That's very helpful. Can I just move on to scenario number 3, because this is a great conversation, but I have got another scenario in it. And sadly, this is very common, this type of scenario physios are phoning in about. I'm going to read it to you. A 17-year-old patient is attending physiotherapy for the first time. The physiotherapist noticed she's withdrawn. It appears she has fresh cuts on her arms. You are unsure how to bring the topic of cuts up, and you feel you need to say something or offer support. And I'm just going to ask the first question. As a mother of teenagers, I'm really interested. Why do some people cut like this? What's the reasons? I'm sure there's many, but...
So that's another complex question. My kids are 5 and 2, so I have some time before they get to be teenagers to figure all this out. And yet I see it with my patients every day. So there are some people who harm themselves in a physical way because that's one of their current tools in their toolkit for how to deal with distress. So when folks have really intense emotions and need to deal with them in some way, they may do behaviors to experience a relief of those emotions. For some people, those behaviors are not as extreme as cutting oneself, but there's sort of a spectrum of behaviors that we all engage in, because all people want to feel okay, to reduce negative emotions, to reduce the feelings of sadness and anxiety. And for some people, it's things that we see as kind of socially acceptable, having a drink, overeating, something that's not necessarily a healthy behavior, but that's a behavior that our society accepts and acknowledges. For some people, that's substance use. For some people, that's kind of other things that we can get our heads around a bit more. And when you talk to somebody who cuts themselves or burn themselves, what you'll often hear is that it's easier to experience physical pain than the emotional pain and suffering. And so they've channeled that distress into a physical source, which is cuts. Sometimes it's also a signal to other people that they're suffering. It can be hard to communicate the suffering. It can be hard to express how you feel, because emotional suffering is internal and it's not something that we wear on the outside, like a cast on our leg or a bandage on our head. And so having symbols of that distress can sometimes be a way to communicate to other people that I'm suffering and that suffering is real. And sometimes for some teenagers, it's a way of trying that out to see if that is a tool that they're going to keep in their toolkit. So not everybody who cuts will continue to do so. And it's actually really common and something that lots of teenagers will try out and see, the same way that teenagers might try smoking. And for some people, it'll be a thing they tried. For some people, it'll be a longer term habit. So kind of understanding it as an outward sign of distress and a way of channeling emotional pain.
And some of the things that I might say if I were to see the cuts on somebody and they're fresh, my first comment might be, it looks like you're dealing with a lot right now. How is the cutting helpful for you? What does it do for you? Because the number of different kinds of responses I've received are, it grounds me, it takes the pain that's inside outside, it gives me something else to focus on. It lets me know I'm alive. It lets me know I'm real. It's to punish myself. There are all kinds. There's a myriad of reasons why people do self-injure. And again, it's critical to not be judgmental. I've had clients who have come in, identified that care providers have said, well, you're so young, you're so pretty, why would you want to do this to yourself? Or this is really going to impact being able to wear a t-shirt this summer. Those kinds of statements are not helpful at all. And again, it's validating empathically the struggle. If you've seen other clients who have self-injured, again, it's, other clients have talked about it being helpful in this way. What's it like for you? How does this help you? Go ahead.
I think it's also helpful to, when there's something that you see with one of your patients that stands out, to comment on it. And we do that regularly because when we're assessing somebody, the way they look and the way they behave is part of that assessment. And to some extent, that is for every care provider. So if there's something that stands out about a patient that you see, that's a potential conversation where we might be helpful to them. So in the very extreme sense, if you see somebody who's, wearing a tinfoil hat to your appointment and not commenting on it would be a miss, because that's often going to lead to a whole cluster of symptoms. If somebody's wearing a maple leaf shirt, you might express empathy for them, and it might be a starting point of a conversation. And similarly, if you notice something about the way somebody moves their body, the marks that somebody has, I think as a healthcare provider, it is totally appropriate, kind of within what is reasonable boundaries. So you wouldn't comment on somebody's level of attractiveness or on somebody's ethnic background, but you might say, look, I noticed that there's some bruises here. Tell me about that. And it doesn't have to be probing or judgmental, but I noticed there are cuts here. Tell me about that. Something that's kind of simple and a potential conversation starter where you might then go on to ask, what does that do for you? How does that come to be? Have you talked to anyone about it? Is that something that you might want to talk to somebody about? So the kind of simple, straightforward commenting on what you notice about somebody's appearance can lead to a conversation that ends up being quite helpful to your understanding of them and potentially to connect them to something else that's useful.
I think it's also really important to know that for some people, because of the role that you have, you may be the first person to see these kinds of cuts that other people might not know about it. And there might be a fair amount of shame. I know that I've had people where I've, identified or asked the question, so do you harm yourself in a way that you do damage to your body? And this can happen for men as well as women. And they've just burst into tears because it's the first time anybody has ever asked or noticed enough to ask. And I think that that's really, really challenging for them. And it's a moment where caring and compassion and empathy are going to get you a long way.
Now, if you, a physiotherapist will know that if, we said this individual was 17, but if this individual was a lot younger and you felt there's risk, you have a duty to report. We know that. A duty to break their confidentiality and get them some help. This is a 17-year-old, and I don't know if the listeners are aware that the legislation changed over the last year, that 16, 17, and 18-year-olds, that you can still report that and get help from those individuals. There's not a mandatory requirement, but still when you report it, there's a duty I'm talking to Dr. Bergman at the moment, but there's a duty we would look into that.
One of the things that I do, because it's still a little bit fuzzy around the 17 and 18-year-olds and what help they will provide or can provide, is I might call on an anonymous consult and get direction from child welfare, from the Children's Aid. And I found that really helpful because they'll let me know if I go further or if we leave it as is at this point in time.
I can say from callers as well, they found the Children's Aid line very, very helpful in situations like that. They've called, they've worked through an algorithm of questions, and they've got some good advice.
Oh, absolutely, yeah. Yeah, again, it's don't do it alone. If you're really, really unsure, call and ask, because otherwise we don't learn either.
So thank you. We've gotten lots and lots of questions are coming in. Would it be okay if we just start to take some live questions?
Sure.
I do have some that have already been submitted, some that are coming in, so I apologize if we don't get round to all of them. I'm going to start off with, it's actually a physiotherapist on one of the outreach sessions that provided this situation to me. She's in a physiotherapy treatment session. It was an outpatient clinic, a sports clinic. She's treating a patient who, she mentioned that she was treating a condition where the patient was lying on a plinth on her back. The patient talked incoherently all of a sudden for 5 minutes, talked with a different tone of voice, became quite panicked. And then after a few minutes, the patient apologized. The physiotherapist was very, very embarrassed and said often pain triggers this kind of behavior. She was very clear she did not want the physiotherapist to mention it to the family doctor, to mention it to anyone. And as the physiotherapist said, she was a little shaken and really was asking the next time this could happen, might happen, what should she do? And maybe Dr. Preisman, would you mind responding to that one?
So I think it's helpful to understand the patient's background there. And that's where I think sometimes when you're working with someone or screening sort of past history, helpful to understand this kind of reaction to something that might be stressful in terms of physical pain or emotional pain. If I had to guess what that person was going through, it sounds like they were at the extreme, maybe dissociating. So the experience of having a traumatic event before was kind of re-entering their mind when they were going through the physical motions or some similar experiences in their session. So it brought them back to that sort of traumatic place, and they became disconnected from their reality in that moment. Or potentially were having kind of an episode of very acute anxiety or a panic attack. And so having a few simple, straightforward strategies to use if you're working with somebody who's in a state of extremely high anxiety or is experiencing something that you're not sure what it is, but it seems kind of scary and you need to have something you might at least try. I think very helpful to sort of check in with the person. Like if you see them sort of fading a bit and not being connected to the moment, to sort of comment on that. Like, I'm noticing things are different for you. Can you tell me what's happening? And if you can't, if things are beyond that, helpful to say their name, to go through some very basic things. And so what we might say is to stop what we're doing, remind that person where we are, what we're doing, what the date is today, what the place is. Those are kind of very basic principles of what Yvonne talked about before, of grounding, of helping you kind of reconnect to your reality. Because what we understand happens for people in those moments is that they go back to a place that's very frightening, that's very scary, that's connected to a trauma that they experienced. So helpful to put them back in this moment. So you're here with me, I'm Mary, I'm your psychiatrist. We're sitting here in our office on University Avenue. You're safe now. We're working together on your shoulder pain or whatever it is we're doing, and to kind of go through that. And sometimes it's even helpful to have that person kind of place their feet firmly on the floor and just go through, like, your body's here in this room in this moment. And if someone has very acute kind of panic where they're sort of gasping for air, they seem to be sort of in this moment where they can't catch their breath, they seem very anxious, really helpful to be able to do a few kind of quick breathing exercises that you can do together with that person so that you can kind of get them back focused on their breathing, slow down their heart rate, slow down their breathing rate, and kind of get them back at least physically in the moment. So I sent around a video that goes through something called box breathing, which is the sort of quickest and most straightforward of those, and I think something helpful for every practitioner to know, which is basically that you kind of breathe as though you're looking at a box. You breathe in for 3 seconds, hold it for 3 seconds, breathe out for 3 seconds, and hold it for 3 seconds, breathe in. So you sort of do this slowing down your anxiety, slowing down your thinking in reverse. So instead of slowing down your thoughts, you slow down your heart rate, you slow down your breathing, sort of bring yourself back. And so that can be a quick and useful skill to have, and just again reminding people about where they are, what you're doing, and if that isn't working, to call for help. Because sitting alone with somebody who's like acutely unwell like that is really frightening for you too. It's very frightening for the patient, but also frightening for the provider. So knowing when you've reached a point where you're no longer comfortable sitting with that person and you need some support for yourself.
And given the fact that the person said, you know, they were very apologetic and that this happens to them from time to time, I will often ask folks, what would you like me to do when that happens? Right. So sometimes somebody will say, well, just call my name. Sometimes they'll say, if you just touch my hand or if you give me a cold cloth, they will give me direction as to what they would like done during that time. I also think that helping them stay in the moment while you're working with them might also help to keep them in the room. So identifying, okay, I'm about to work on this part of your anatomy. This is the pain you're going to feel. It's only going to be momentary. It could leave you with some, talk about the experience of the pain or the physical sensations they're going to have so that there's a framework for the here and now versus them going into a place that they may have previously experienced where it's been a similar sensation for them, either emotionally and or physically.
Okay, I'm going to move on. The questions are really coming in now. I wonder if I can take this one. I work with First Nations clients. When I suspect abuse, how do I ask the question in an Indigenous framework where they will be afraid, where I know they'll be afraid to tell, knowing the repercussions within the community? Well, that's a difficult one.
Well, both Mary and I are looking at each other going, okay, who's going to do this one?
Very tough one.
Yeah, it is a tough one. I know that here in Toronto, what I tend to do if I'm working with somebody from a culture or a tradition that's very different from my own, I will ask for a consult from, an organization or a person from that culture. If I am working, and this is generally with adults, say, I've got some questions, but I'm not sure how to ask this in a way, and I don't want to be rude and I don't want to offend you. So if I want to ask you about questions of safety, what are some of the ways in which I might do that? Because I really don't want to be offensive. So I'm letting them know that I don't know what I don't know. I don't know, or I know what I don't know, and I need them to teach me as well. So I will ask in that way. As I said, I will often consult with another organization or somebody who is better informed on that culture than I, to be able to say, okay, what would be appropriate here? How do I start the discussion without making it worse?
I think also helpful sometimes to ask the patient. So if you don't have access to consultants who are able to give you that kind of information, saying to the patient the same thing, like, I'm not familiar with what happens in your community, and so I want to be helpful to you. I want to provide something that's useful, and you teach me what I need to know about your community and your culture and your faith so that we can figure something out together. That might be a way to start that.
And I find that clients really, really respond well when I say to them, okay, you be the teacher, I need to be the learner here. because there is such a power imbalance in our relationships. By virtue of us being professionals and them being the patient, it sort of takes it to a different level by saying, you be my teacher here. So it does a lot for the relationship as well.
So maybe we'll have time for 2 more questions. There seems to be a lot coming in around the topic of abusive relationships. One physio was asking if you noticed a patient with bruising who discloses that they're in an abusive relationship and you're not supposed to tell anybody and the patient says they're okay with it, what should I do? And they've said to me they can handle it.
So that's really difficult for the patient and the physiotherapist in that situation. And so I think helpful to comment on that actually. So a lot of times it's helpful to say what you're thinking, especially when you have the sense that it's that way for the person that you're working with too. So I think totally appropriate to say, you know, I'm seeing that and I'm seeing that you're struggling and I feel like I want to help you and I'm not sure what to do. I'm here to listen. I'm here anytime you want to talk about what you might do. And so I feel a bit conflicted because it sounds like you're in a place where you're staying where you're at for now. And maybe that's something we can work on and maybe it's not. I'm happy to continue to work with you and to support you. Want to talk to you about things that might be risks around your safety. And if you feel comfortable, you could provide some education about sort of those higher risk times, what other people have done to get out of the situation, and a sort of non-judgmental, like that sounds like it's not right for you right now. It might become right for you in the future. And so next time we meet, let's keep talking.
I have another question, a very interesting one. I treat neonates. Often the family can be so distressed and they do cause disruption during my treatment session. Overly anxious, for example, about hygiene, washing hands, not wanting the physiotherapist to touch their child. It's so very hard to be supportive and assess or even treat their baby, but the baby needs the treatment. Any advice?
So I work with the postpartum population at Mount Sinai Hospital.
Oh,
so I see this a ton. And so it's always confusing what is kind of normal new parent anxiety versus what is a more serious anxiety. And that's not necessarily for us in any of our roles to address right then. I think what's helpful to say is what would make you feel most comfortable. It looks like what I'm doing now is kind of anxiety provoking or is stressful. And so I want to be able to do my assessment and I want to be able to work on the things that have been identified for your babe that are a struggle. Tell me how I can make you feel comfortable. And so if that is they want you to wash your hands 2 times or use this type of hand sanitizer, or they feel like they need to stand really close by, sometimes allowing those things, assuming they're safe and relatively reasonable, can just help you do the work that you need to do. And so when you see somebody who's very clearly uncomfortable, always helpful to say, what can I do to help you feel more comfortable?
I have one question that came in, and I know at the beginning, Dr. Bergman, you actually gave some really good advice to me. It's when a physiotherapist, they're finding it hard to wrap up a session, or the patient goes to leave, and then out comes a disclosure of some sort. Can you repeat the conversation that we had before the session begun?
Well, I think there are a couple of things that we can do. One is when we start the session is let them know how long the session will be. And then about 5 minutes prior to the end of the session is saying, well, we have about 5 minutes left. So I'm wondering, what is your schedule like for us getting together again? Is it better to do it, at this time, on this day? So what you've done is you've given them the warning, you've given them the heads up, and then you've just basically said, okay, we got 5 minutes and let's talk about our next meeting, so that they actually know that there is going to be another meeting. And that, yeah, it's over.
I like to end my sessions by saying, we're done for today. And just making it so explicit, like that's how we end our sessions, is that's our time for today, which is kind of what's happening now in this webinar as well.
Well, I've got one more question coming in, and I just feel it should be addressed. It's obviously somebody, they're quite upset. A patient has emailed me saying they're not coming in because they're going to kill themselves. How do I respond? It's not a face-to-face, it's an email.
I send a police officer for a safety check. Right. I can do that here in Toronto. I don't know what it might be like in other communities, because they've given you no other information. It's not your role to get into a counseling situation. I'd say, you know what? This is the information you gave me. This is what I need to do.
Call 911.
Sending a police. Well, sometimes what I'll do is I'll call the local police department to where the person is, or I'll call the radio room and say, I've got somebody who I think is in some distress. Could you do a safety check? And so the uniformed police officers will go. I know in Toronto, we also have the mobile crisis team that we can ask to go in. Hamilton has the Coast team. Peel Region, I know, also has a team as well that will go and check and do a safety check.
So I would absolutely agree with that. I think that when there's that level of potential safety risk and nothing else you can do, doing the safest thing always makes sense. If you communicate with your patients by email, which I do, and that's different in different people's practices and what is the norm. If you don't email with your patients, then you continue not to email with your patients. But if you do, when I get emails like that, I say, I'm really worried about you. I encourage you to go to your nearest emergency department right away, because this is extremely urgent and safety is most important. I'm going to do what I think is the safest thing now. And you can say what that is, or you can leave it at that, so that you've communicated how seriously you're taking this to the patient. And if there's an email correspondence, I would print it for their chart if you have a paper chart. Make sure it's clearly documented what you did in your electronic medical record, or however you're keeping notes, and just make sure that whatever steps you've taken, that you've made that pretty clear and outlined. So if there's any repercussions about what you ended up doing, it's very clear you did that because you were so concerned about that person's safety.
Okay, I'm looking at the time. I do not want to wrap this up. I find this conversation very, very interesting and helpful. I do want to remind listeners there'll be a lot of resources being sent out tomorrow that hopefully you can print out, have in your practice, resources, videos on the box breathing technique. And we hope this conversation continues. And I want to thank everybody who's tuned in for this webinar.
Thanks so much for having us.
Thank you.